going to be talking quite a bit about diabetes, but I'll also cover some other issues in that common endocrine problems that come up in exams and common things that you have to know for both the Diploma of Child Health and the Masters of Medicine. So both for the exams, but also just to be good depaediatricians. I'm going to talk quite a bit about diabetes at the start, and because I want you to know how to look after a child who's got acute diabetic ketoacidosis, and I want you to know how to then manage the child who's got diabetes in the longer term. So I'll talk about that, and then we'll cover a few other things. Okay, so this is a typical blood gas picture. In fact, I saw a child just yesterday who was 2 years old, who looked like this. But this was a 7-year-old girl who'd been unwell for 3 weeks. She'd had weight loss, she was lethargic, and she had respiratory distress. Of course, she could have had anything, but this was what her blood gas showed. And I want you to have an understanding of what blood gases tell you and what they show. So for this child, her pH was 6.9, so that's very low. So she's got a severe acidosis. Her carbon dioxide level was very low as well. Normally that's 35 to 45, and it was 11. So that suggests that she's breathing very rapidly, but still not correcting her pH. So despite breathing very fast and blowing off a lot of carbon dioxide, her pH is still very, very low. Her oxygen level was fine, 101, that's normal. And that suggests that she's got normal lungs. Her bicarbonate is very low, and that again suggests a metabolic component to the acidosis. This girl's got a severe metabolic acidosis. Her base excess is -22, and sometimes that's called a base deficit, sometimes it's called a base excess, but it means the same thing. The base excess is -22, so a very large base deficit in her blood gas. And so this is a severe metabolic acidosis that's poorly compensated. Despite her breathing very fast, her pH doesn't come back to anything like normal. I mean, normal is 7.35 to 7.45. This girl's sodium was 128, so a bit low. Her potassium was a bit high at 5.6. Her chloride was a little bit low, and her urea was a bit up, and her creatinine was a bit up as well. So urea and creatinine being a bit up. And so this is a typical blood gas of a child who's got severe diabetic ketoacidosis, who is very acidotic, is dehydrated, and has some renal impairment. That's very typical. Whenever we see a severe metabolic acidosis like this, we need to ask, is it well compensated or is it poorly compensated? And in this case, the child is trying to compensate as much as they can, breathing very fast, but still the pH doesn't get back to normal. And the second question is there an anion gap? And you can work out the anion gap by the sodium plus the potassium minus the chloride plus the bicarbonate. So the cations minus the anions. And this girl's anion gap was 39.6, so nearly 40, and a normal anion gap somewhere between 3 and 10 millimoles per litre. So her anion gap was very large. And whenever we see a severe metabolic acidosis, we should ask, is there an anion gap? And if there is an anion gap, we should ask, what are the unmeasured anions? Why is there such an anion gap? And in this case, the anions were mostly because of the keto acids. So her lactate was 3.3. That's not a keto acid. Excuse me, I'll just get the phone. Hello, it's Trevor. That's right. Oh, I see. Yes, I do. I'll send you her email. Yeah. Yes, I've got both of the. Yeah, I've got Dave's story and Parker. Yep. Okay, I'll do that. Yeah. Yes. Right. Okay. Well, Anapaka usually responds quite quickly. So yeah, okay, I'll yeah. Yes, I think so. Yeah, I'll send you the email. I can't quite remember it now. Yeah, yeah. Okay. Yeah, yeah. Yes. Okay, no worries. I'll let them know. Okay, bye. Sorry about that. Yeah, so any time we see a large metabolic acidosis, we should be asking ourselves, well, what's the anion gap? And if there's a large anion gap, we should ask ourselves, well, what are the unmeasured anions? What makes up the gap? And it could be lactate. Lactate is a very common anion that can make up the anion gap. But in this case, the lactate of 3.3 isn't anything like 39. But this child's anion gap is made up of ketoacids, all the acids in the blood from ketoacidosis. I'll just admit dianolita. And the child's glucose was very high, so 35 millimoles. So when we see a metabolic acidosis, when we ask what the anion gap is, sometimes it'll be a mixed cause of a wide anion gap. It could be lactate, it could be ketones, and so that's the typical blood gas of a child who's got diabetic ketoacidosis. Now, type 1 diabetes is increasing all around the world, and certainly in Australia, the number of cases of type 1 diabetes has increased at a very large rate. I mean, you might think that's a lifestyle thing, but in fact, it probably isn't. It's probably not related to, progressive obesity, because remember, it's type 1 diabetes. Now, there have been cases of type 1 diabetes reported in PNG since 2000. Of course, there's a lot of cases of type 2 diabetes, and we know that type 2 diabetes is increasing in children and adolescents throughout Australia, New Zealand, Polynesia, and in PNG, particularly in adults, but also in adolescents as well. And the clinical features are, I'm sure you know them, but children who have weight loss, they first of all start being very thirsty because they've got glycosuria and an osmotic diuresis. So they get dehydrated, they have weight loss, polyuria, vomiting often because of the ketosis. When they become ketoacidotic, they often have vomiting and abdominal pain. So vomiting and abdominal pain is a common presenting feature. I saw a child just recently who presented with what was thought to be appendicitis, but in fact it was just diabetic ketoacidosis. And then confusion and coma, and they progressively lapse into coma because of the severity of the acidosis and the ketosis and other electrolyte changes. It's important to know what insulin does. We've talked about this in another lecture, but insulin is the main hormone for energy storage and anabolism, for growth and adding muscle and adding glycogen. And when you've got insulin, glucose enters cells, and it gets stored as glycogen in the liver and then stored as triglycerides in fat. So whenever we eat a meal, then we have a burst of insulin, and that pushes glucose into cells, and the glucose gets stored. But if you don't have insulin, then you have a lot of other what we call counter-regulatory hormones being active. So that if you think about it, insulin is one of the anabolic hormones, and the catabolic hormones are like cortisol, adrenaline, etc. So when you don't have insulin, glucose doesn't get into cells because insulin is needed for glucose to enter cells. So you get hyperglycemia. The glycogen in the liver gets broken down. Triglycerides in fats gets broken down. And because of the breakdown of muscle to amino acids and fatty acids, they can combine to form glucose in the liver. So you get the liver trying to make glucose because not enough glucose can go into cells because of a lack of insulin. So it's a little bit like this. If you have insulin deficiency, then the child will have hyperglycemia, they'll have glycosuria, and they'll have loss of water and electrolytes, and they'll get dehydrated. And because of that, you have a counter-regulatory hormone response where you have high levels of glucagon, growth hormone, cortisol, and especially adrenaline and glucagon particularly. And they act on 3 different organs. They act on muscle, they act on the liver, and they act on fat tissue. And they act on muscle to lead to protein breakdown, and that mobilizes amino acids that then can form glucose in the liver when they're combined with glycerol. In fat tissue, when you've got lots of glucagon and adrenaline, that causes breakdown of fat tissue to what we call lipolysis, and that releases triglycerides and free fatty acids, and they get converted to ketone bodies. That's what the ketoacidosis is due to, the ketone bodies of the free fatty acids that occur because of lipolysis, that occur because there's not enough glucose. And ketone bodies can be a source of energy for the brain particularly. So as you know, when during ketoacidosis, the blood sugar is high, but the brain doesn't have glucose because glucose can't enter the brain cells because there's a lack of insulin, but the keto acids can. So it's actually quite, ketoacidosis is a protective mechanism in the setting of insulin resistance or lack of insulin, that's the energy source for the brain typically. I'll just let a couple of people in. When we're looking at when we're looking to know how much how sick a child is, then these urinalysis sticks are really useful, and I would encourage you to read more than just the white cells and other things, but the ketones are very important and the glucose is very important. So we can check whether a child's got glycosuria. Remember, glycosuria occurs usually when the blood sugar is around about 9 or 10. And certainly if the blood sugar is 12, then there'll be glycosuria and an osmotic diuresis. That means that with every molecule of glucose, then there'll be molecules of water being excreted. And that's why the child gets dehydrated, because their blood sugar is running very high all the time. Then they're spilling glucose into their urine all the time, and subsequently water gets lost with that in the urine. So check the ketones, check the glucose on the urinalysis sticks. Now the ketones are very important. We should keep treating patients with diabetic ketoacidosis until they've cleared their ketones completely. And so I just wanted to talk a bit about the pathogenesis of type 1 diabetes. I mean, it's important that we know something about the pathogenesis. It's really it's caused by autoimmune destruction. So destruction with the immune the immune system of the beta cells of the islets of Langerhans, which are in the pancreas, of course. And the beta cells of the islets of Langerhans are those that produce insulin. And for some reason, children get autoimmune destruction with an influx of white cells and inflammatory cells that cause destruction of the islets of Langerhans. It doesn't occur all at once. And so when a child has diabetes, usually they've been sick for quite some weeks or months, often many months beforehand. You may find T lymphocyte infiltration of the islet cells, as I said, months or even years beforehand. And we think that some children have a genetic susceptibility, but diabetes does seem to be triggered by different environmental agents, particularly viruses. And when we look at children who've got diabetes, about 30 to 40% of all children who've got diabetes have antibodies to Coxsackie virus, which is just one of the enteroviruses. It's a very common virus, and but about 30 to 40% of children have antibodies to that. So suggesting that they've had a recent viral infection that's led to antibodies being produced that lead to autoimmune destruction of the islet cells of the pancreas, and then lead to a progressive loss of insulin production. It was interesting last year that, I'm not sure whether you've seen it at all, but last year, even though we didn't have too many children with COVID who were severely ill with severe respiratory infections or anything, we did see an increase in diabetes during the period of the peak COVID in Melbourne. And I did wonder at the time whether or not perhaps the antibodies that are produced to COVID might actually also lead to diabetes. That's been reported in other countries as well, that that during the really peak times of the first waves of COVID, that there were more patients presenting with newly diagnosed type 1 diabetes. What happens when you've got diabetic ketoacidosis is you have insulin deficiency. As I said, that leads to hyperglycemia. You then have catabolism, that's the breakdown of fat and protein, and that leads to the release of ketone bodies, which provide alternative energy because you don't have glucose going into cells. So the ketone bodies provide an alternative source of energy, but it also leads to severe acidosis. The children get dehydrated from vomiting, from the osmotic diuresis, from glucose and ketones, and from that they get a severe acidosis. And the acidosis is due to both the ketosis and the severity of the dehydration. Most children who've got diabetes have quite low levels of potassium in their body. And so remember that mostly potassium is contained within cells, but you also need insulin for potassium to get into cells. And so most children with diabetes, with diabetic ketoacidosis, have very low levels of potassium in their body, but they may have high levels of potassium in their blood. And the reason for that is that they may have potassium in their blood that can't go into cells because they don't have insulin. And the other reason is that they may have impaired renal function, and because of that, they retain potassium. The treatment for diabetic ketoacidosis is fairly simple, but it's important that we know how to do it. And I think we can all learn how to treat a child who's got diabetic ketoacidosis. We basically have to correct the shock if it's present. And not all children with DKA have shock, but many of them do by the time they present. And sometimes if they've got poor pulses, if they've got other signs of shock, then a fluid bolus of 10 to 20 mils per kilo is appropriate. Don't give too much fluid though. Don't give excessive boluses of fluid, because children with diabetic ketoacidosis are prone to cerebral edema. And it's best, I generally just make sure their blood pressure's okay, their pulses are all right, they're not cold peripherally, and then after that I stop giving them boluses of fluid, usually not more than 10 or 20 mils per kilo. You then calculate to correct the dehydration over about 48 hours. So could someone who's got their device on and talking, could you perhaps mute your device? Thanks. You try to calculate to correct the dehydration over 48 hours, and I always use isotonic fluid for that. So something like Hartmann's solution or Ringer's lactate is okay. Normal saline is all right, but it makes the acidosis worse, of course. Don't use a hypotonic fluid. Don't use 4.3% dextrose and 1/5 normal saline, or don't use that fluid because it's not got enough sodium in it, and that can lead to cerebral edema in some patients. Sometimes in diabetic ketoacidosis, we end up overestimating the degree of dehydration because the patients are tachypneic and they're acidotic. But patients with diabetic ketoacidosis will have some dehydration, and many will have severe dehydration. You need to replace the potassium deficit. Remember I said that all patients have a total body potassium deficit, even if their measured serum potassium is high. But if their potassium is low, then I usually start them on some potassium replacement in their rehydration fluid, usually 40 to 60 millimoles per litre in the rehydration fluid. I'll explain how to make that up. And then you can commence an insulin. You commence the child on insulin, and there's two ways to do it. One is with an insulin infusion, but that's quite hard to do. And I think if you're in a setting where you've got an insulin infusion, you've got infusion pumps, then that's fine. You can use an insulin infusion, and it's quite safe to do as long as you've got regular monitoring of the blood sugar. Could those who've got the devices turned on, please turn them on?
I think it's Dorothy. Dorothy,
okay.
You can mute your.
Okay. All right. Sorry about that, everyone. There's two ways to give insulin. One is by giving it as a continuous infusion. That's fine if you've got insulin, if you've got infusion pumps. But if you don't have that, then what I do is about every 4th hour, I give somewhere between usually 1 unit per kilo over a 24-hour period. So divide that by 6 and then give that subcutaneously. If you give that starting with 1 unit per kilo per day, and then divide that total amount by 6, and then give it every 4 hours. That's another way to give it for children who've got diabetic ketoacidosis. As I say, if you've got an insulin infusion, if you've got an infusion pump, then you can give an insulin infusion in a 50 ml syringe. That's fine as well. But if you don't have that, then giving 1 unit per kilo per day stretched over in 4 hourly lots is also an okay way to do it. And that will eventually, that will get the blood sugar down and it'll get the patient under reasonable control. I wanted to go through just how we calculate both the fluid replacement and the insulin replacement for children with diabetes. So this is this 7-year-old girl who had dehydration and diabetic ketoacidosis, and she presented with severe DKA. And this is the insulin dose you could use. So you can use 1 unit, 1 international unit times 20, because she was 20 kilos. So that means that over a 24-hour period, she just needs 20 units of insulin. You can't give it all at once because it acts rapidly, depending on the type of insulin, it acts rapidly. So you just divide it, divide it by 6 and then give that every 4 hours. So that roughly equated to 3 units every 4 hours. You've got to make it very regularly every 4 hours, and you've got to check the blood sugar at the end of the 4-hour period just to see that whether you need to give a little bit more or a little bit less. That's very important. And then the second thing is, so you've decided the way you're going to give insulin, and the second thing is decide the way you're going to give fluid. And most children with severe diabetic ketoacidosis are around about 10% dehydrated, sometimes more, sometimes a bit less. And so you can work out what her deficit is. 10% of 20 kilos is about 2 litres. And her maintenance is 10 times 100 mils per kilo for the first 10 kilos. So that's 1,000 mils. And 50 mils per kilo for the next 10 kilos. And because she's 20 kilos, that's a maintenance of 1,500 mils plus 2,000 is her maintenance over a 24-hour period. So if we wanted to replace the deficit over 48 hours, that's 2 litres divided by 48. So that's 42 mils an hour. And her maintenance fluid is 1,500 mils. So 1,000 plus 500, 1,500 mils over 24 hours. So that's 63 mils an hour. So you need to give this child about 105 mils per hour for 48 hours to replace her deficit. And if you gave her 3 units of insulin every 4 hours and 105 mils per hour for 48 hours, then her ketoacidosis would resolve, usually within about 24 hours. I just had a child admitted yesterday with, as I said, a 2-year-old boy who has newly diagnosed diabetes, and he got this regime, this type of regime, and now his blood sugar is normal, his ketones are cleared, and he's awake and talking, and he's actually doing fine this morning. So you can use this type of regime and correct diabetic ketoacidosis within 24 or 48 hours. The way we monitor children with diabetic ketoacidosis, we should monitor their clinical signs of dehydration. You should look for a fall in blood sugar. So usually when the blood sugar falls below 12 millimoles per litre, that's the blood sugar, you should add some glucose to the hydration fluid. So if you were just using Hartmann's solution before, you might add Hartmann's solution plus 5% dextrose, because you want to keep the insulin going until, like I've described, you have to keep the insulin going until you get resolution of ketosis. And that's often the last thing to improve. So this boy that I described, his blood sugar came down quite quickly. Within a few hours, but it's only this morning that his ketones in his urine have actually cleared completely. And the resolution of ketosis, it's important. Sometimes people stop insulin when the blood sugar comes back to normal, but that's not right. You should keep insulin going until you get resolution of ketosis. And with that, you should get resolution of the dehydration. The blood sugar should be normal. The ketosis should have resolved. And usually the sodium should increase. You remember this girl that I described, the 7-year-old girl, had started with a sodium of 128. And what you should be aiming to do is to see the sodium increase a bit after you start insulin and get the patient on the right regime of insulin. In any child who's got diabetic ketoacidosis, we should always ask, well, why did this child present now? What's the thing that caused them to present? Is it some infection? Have they got a staphylococcal infections are quite common, both as events that cause diabetic ketoacidosis, but also as a consequence of having hypoglycemia for some days or weeks. Staphylococcal infections are quite common. Some children get urinary tract infections, and that can trigger DKA as well. And then fungal infections. All of these things, diabetic ketoacidosis is a immune compromising condition, because if you've got hyperglycemia, then that makes us much more susceptible to infections like staph infections and fungal infections particularly. So we should always ask the question, why did this child present now, and what are their comorbidities? What sort of infection do they have? I wanted to then now talk about what you do after that, because I think this is sometimes a little bit confusing to people. After you've treated their diabetic ketoacidosis, what do you do? Well, you need to know something about the types of insulin that are available. And I have a very simple understanding of the types of insulins that are available. There's many more than this available, but I break it down into just 4 different types. Firstly, rapid acting insulins. So there's an insulin called Nova Rapid, which is very rapid acting. Regular insulin, which we often use, we call Act Rapid, which is also fairly rapid acting. So these rapid acting insulins, the first 2 are rapidly acting insulins, and they work within 15 minutes to 30 minutes to an hour. And then they have a peak of insulin level, which is somewhere between 30 and 60 minutes for Nova Rapid and 2 to 4 hours for Act Rapid. And so when you give the insulin, that will deal with the blood sugar that goes high after a meal, right? Because it doesn't work immediately, but it'll work within 15 minutes, and that's the time, 15 to 30 minutes, that's the time it takes for a child to eat a meal. And then their blood sugar will normally be up for the next few hours, but the rapidly acting or regular insulins, they will deal with the blood glucose level rise that occurs during meal times. And then the duration is 3 to 5 hours or 5 to 8 hours for Nova Rapid and Act Rapid. So these are the 2 more fast acting insulins to deal with blood sugar levels at meal times. Then the next types of insulins are the intermediate acting insulins. And so if you know about 2, know about the regular one and the intermediate one. I think the intermediate ones the onset is somewhere between 1 and 3 hours, and they peak at around about 8 hours. So when you're giving insulin in the morning, that's really in the intermediate insulin, that's really for the rest of the next 8 hours, even the next 12 hours until the evening. And so they will bring the glucose down throughout the day. During normal normal activity and normal eating throughout the day, they will manage the blood sugar during and the body's general insulin and glucose needs. And so they can last for 12 to 16 hours. And so these types of insulins there's 2 that are commonly used. One's called Protophane and the other one's called Humulin. And remember, they manage the general body insulin needs throughout the day, not so much deal with the meals. And so often then we use because of that, because they have different durations of action, peaks of action, and functions, we often use a mixed form of insulin. So the 2 forms of insulin that are mixed, that are readily available, are Humulin mixed insulin. So Humulin 30/70, which means it's 30% short acting and 70% intermediate acting. So that's all it is. And mixed hard is the same, 30/70, 30% short acting and 70% protophane, which is the intermediate acting insulin, right? So when we are thinking about how to give insulin, think about the rapid acting insulins and the intermediate acting insulins. You really can't treat a child with diabetes on an ongoing basis if you don't have at least those two insulins. There are some other long-acting insulins that go for 24 hours, but rarely we use those. Usually we use 2 injections a day or more, but at least 2 injections a day of a combination rapid acting and intermediate acting. That's the standard way to treat diabetes. Sometimes, of course, these days children have more injections a day, or they have an insulin infusion pump. But if you want to do the basics, then it's 2 injections a day, morning and night, before breakfast and before dinner, and that deals with the glucose needs for the day. When you're establishing a child with type 1 diabetes on treatment, then I usually start. So this boy this morning, I started him on 1 unit per kilo per day of insulin, and just with 2 subcutaneous injections in the morning and at night. And I usually give 2/3 of the total daily dose in the morning and 1/3 at night. So 2/3 morning, 1/3 at night. That makes sense because you're eating more in the morning and during the day than you are at night. So 2/3 in the morning, 1/3 at night, and then give 1/3 as the short-acting insulin and 2/3 as the intermediate-acting insulin. So act rapid and protophane insulin usually, or Humulin. So that's the formula, and usually you have to adjust up or down a bit over the first few days, but that's usually a good starting point. So 1 unit per kilo per day, 2 subcutaneous injections, 2/3 in the morning, 1/3 at night, 1/3 short acting, 2/3 as intermediate acting. So this 7-year-old girl with diabetes, if she's 20 kilos, so 20 units, 2/3 in the morning is 13 units, 9 of which is intermediate acting, 4 of which is the rapid acting, and 1/3 at night, which is 7 units, 5 intermediate acting and 2 act rapid. So that's how you make up the 20 units for the day. 9 plus 4 plus 5 plus 2 is 20 units for the day. And that's just a good start. You may need to adjust up or down, morning or night, depending on how she goes, but that's usually a good start. You mix the insulins together, so you're just giving 1 injection, and you give it subcutaneously in the thigh or the abdomen, in the lateral part of the abdomen, and you wipe the skin with an alcohol swab beforehand, just so as you don't get a staph infection under the skin, because that's quite common in children with diabetes. In regards further ongoing management, the diet of a child who's got diabetes should just be a healthy diet. You don't need to you don't need to be restrictive about the diet, but it should be healthy. And the problem is most of us don't eat a healthy diet. We eat too many complex carbohydrates. We don't need enough fruit and vegetables, particularly vegetables, and we eat a lot of processed sugar. And so they're the things to really avoid in children with diabetes: complex carbohydrates and processed sugar. And there's a thing called the glycemic index that you need to know about. I'm sure that most of you know about this, the glycemic index. But when we drink or eat foods that are made of complex carbohydrates or lots of processed sugar, then our blood sugar rises very rapidly. And so the things that have a high glycemic index are things like fizzy drinks, Fanta or soft drinks, rice, white rice, chips and cheese pops and biscuits and white bread and ice cream. They all cause our blood sugar to rise really rapidly. So they cause our insulin levels to go up very high. And that's part of why type 2 diabetes is so common, because people who are eating food like this end up having high levels of insulin constantly, it's better if you can eat more complex carbohydrates. So vegetables, oats or porridge or pasta, orange, fruits and vegetables, brown rice particularly, vegetables like cacao and greens and cabbages, they all have a very low glycemic index. And so children who have diabetes, the main thing is to try to avoid them having lots of complex carbohydrates and having too much sugar. But if they eat healthy, not too much processed food, then that's what they need. They need regular exercise. They need their insulin at home. They need a refrigerator at home because you have to keep the insulin in the refrigerator. They need a glucometer, so it's important that you get them a glucometer and teach them how to use it, and teach them how to check their urine for ketones and glucose, and have some glucose sticks. So they need a glucometer and they need glucose sticks. I always give the children a logbook so that they can record, maybe not every day, but several times a week, record what their blood sugar is in the morning when they're checking it. And usually about every 6 months, I check their what's called their hemoglobin A1C level, which is sometimes their logbook tells you whether they've had good control or not, and sometimes they don't always record their blood sugars. So you can measure their hemoglobin A1C, which is it's called glycosylated hemoglobin. It's hemoglobin that's got glucose on it. And if you have poor diabetes control, then your blood sugar levels will be high and you'll have more hemoglobin A1C, glycosylated hemoglobin. And the normal glycosylated hemoglobin is somewhere between 4 and 6%. But I've seen patients recently that have had glycosylated hemoglobins of 8 or 10%. And so you know that in the last few months, they've had quite poor control of their diabetes. Even if their blood sugar seems to be within the normal range now, it's because of their poor control over several months that their hemoglobin A1C level is high. The risks of diabetes, in children who've got diabetes, we need to be looking out for hypoglycemia, and that's quite common because children might not eat normally or eat regularly, and if they don't eat regularly, then they're really prone to hypoglycemia if they take their normal insulin. And that's why checking insulin regularly is really important, and that's why even overnight hypoglycemia can lead to seizures and other things. And so it's really important that children monitor their blood sugar very carefully so that if they're having hypos, because it's possible for children to even die suddenly overnight or have seizures because of hypoglycemia, because they haven't eaten enough during the day and they've taken their normal insulin levels. The symptoms of hypoglycemia, hypos, are palpitations, tachycardia, dizziness, pallor. Often children look very pale, they look weak, and sometimes they have seizures. These are all the symptoms. And I always teach children with diabetes that, to know the symptoms of hypos, so that if they do feel weak, then they should take some, a source of glucose, a glucose-containing sweet or something. So they should always carry with them something like that. And if they feel that they're feeling dizzy or they're feeling weak, then they take some glucose. If patients are having hypos, then we should reduce their nighttime insulin, especially if they're having overnight hypoglycemia. That's probably the most dangerous thing, if they're on too much insulin in the evening and not taking enough food. In the longer term, we need to look out for the complications of diabetes, which occur in adults mostly, but we can start to see the long-term issues in children with diabetes from adolescence onwards. And so every young older child or young adult who has diabetes needs to be checked for diabetic kidney disease. So particularly check their urine for proteinuria. They should see an ophthalmologist at least once a year to check for signs of retinopathy, which is a bit like I talked to you a few weeks ago about retinopathy of prematurity. Well, the retinopathy of diabetes is rather similar. It relates to neovascularization and new vessel formation in the retina, and then bleeding, and a bit like macular degeneration in old people. Diabetic retinopathy can be detected early and it can be treated early. In fact, it can reverse if you get your diabetes under better control. Some children with diabetes end up with peripheral neuropathy, and again, all of these complications can be reduced by having good diabetes control. They're not inevitable results of having diabetes. They all relate to the quality of the control of the diabetes. Children who've got can develop, even in adolescents, cardiovascular disease like coronary artery disease early in life, or peripheral vascular disease. These are very complications that can sometimes be avoided. And I've talked before about fungal infections and staph sepsis, and sometimes it's important you don't inject in the same place, because insulin causes atrophy of fat, and sometimes you get fat breakdown in areas where you're giving insulin injections. So I always rotate the injections in different parts: left thigh, right thigh, upper and lower thigh, the abdomen on the left and the right side. So tell the children to rotate the insulin injections they have to give each day. Okay, that's all I wanted to say about diabetes. I'm happy to answer any questions about that, but I wanted to say something about some other endocrine problems, and particularly say something about just a few things about growth, because I think we often think about growth in terms of malnutrition, but of course growth can be an endocrine problem as well, and it can be both genetic and hormonal. And so when you're thinking about children with poor growth, I want you to think about 3 different causes. The first one is genetic, and of course it might just be constitutional short stature. The children are short because the parents are short. That's the common thing. Children are short because parents are short. But there are some genetic abnormalities that can lead to short stature, such as achondroplasia, you know it as dwarfism, or Turner syndrome, that's female XO chromosomes. And those children are particularly short. It can be nutritional, but I won't talk about malnutrition today, or it can be hormonal. And children who've got growth hormone deficiency or hypothyroidism, or have excessive exposure to steroids, they can have endocrine causes of failure to thrive or failure to grow. Failure of linear growth is the main thing. So you'll be familiar with some. I'm sure you've seen a child who's got achondroplasia, but this is the typical. These are the typical features of a child with achondroplasia. They have shortening of their limbs, particularly in the middle part of their limbs, in this upper part. They often have a large head, although their head's usually not very large compared with a child who's a normal size, but it does appear very large for their own size. They often have what's called frontal bossing, a bit like children who've got thalassemia have frontal bossing, a prominent forehead. They have a small mid-face and a flattened nasal bridge, and they often have a thoracic kyphoscoliosis because a curvature of the spine. And sometimes they often have other spine problems, like a compression of the spine at the level of the neck, at the foramen magnum. They can have spinal cord compression because of their abnormal spine. And so children who've got achondroplasia, their brain is normal. They're of normal intelligence. They're very bright, well-functioning children, and they can lead a good life if they don't have any other problems, like particularly the spinal problems. So it's important to recognize these patients and recognize that they have a normal brain. They're as intelligent as you or I, but they just have some orthopedic and often spinal problems. Achondroplasia is due to a cartilage defect, a bony cartilage defect. It's a mutation. There's multiple mutations actually that inhibit chondrocytal cartilage proliferation in an area of bone growth. And so normally our bones grow because of the progression of cartilage, but the cartilage doesn't grow in the area of bone growth. Normally cartilage grows and then it gets replaced by bone, the ossification of bone, but but there's an inhibition, a genetic defect causing a lack of cartilage growth. The children, as I said, have normal intelligence, and most children with achondroplasia will be healthy, but sometimes they have some problems with, because of narrowing of certain bones. So they have recurrent otitis media because of a narrowing of the eustachian tube in their ear. They can have chronic serous otitis media, or they can have spinal cord compression because of a narrowing of the bones in their spine, around their spine. Or sometimes they can have hydrocephalus, an obstructive form of hydrocephalus, because of the narrowing of the spinal canal. And sometimes they also have sleep apnea because of they've got compression of the brainstem because of the hypertrophy of their bones. Children with Turner syndrome can look a little bit like children with achondroplasia, but they're actually quite different. Girls with Turner syndrome have XO, so instead of having XX, they have XO. They have short stature, and this girl shows the characteristic features. She's got a wide chest. You can see how broad her chest is and how short her upper arms are, and you can see that she has a webbed neck. So the characteristic features are the broad chest and the widely spaced nipples and the webbing of the neck. That's typical of a child who's got Turner syndrome. In a similar way to children with achondroplasia, they can also have kyphoscoliosis and problems with their spine. But they can also have heart problems, so coarctation of the aorta, or a bicuspid aortic valve. Children with Turner syndrome often are born with heart problems. They can also have some horseshoe kidneys and other things as well. Boys can look the same as children with Turner syndrome, but they have what's called Noonan syndrome. It is different, and instead of having left-sided heart problems, they have right-sided heart problems. It's just a strange thing where almost the same phenotypic condition. They have a broad chest and they have webbing of the neck, but if it's a boy, it's called Noonan syndrome, and they're more likely to have a hypertrophic cardiomyopathy, a hypertrophic obstructive right-sided cardiomyopathy, whereas girls have coarctation of the aorta, a left-sided heart problem. I wanted to just briefly touch on hypothyroidism because I think we need to know about that. It's an important condition. It's probably quite common. It's certainly quite common in some parts of PNG. In Chimbu, for example, there's a bit more congenital hypothyroidism than elsewhere. And these are the features of hypothyroidism. This is a little baby who had hypothyroidism. You can see the baby has got a large tongue, a coarse face, so that the face has got, it's like, there's a term called myxedema, which more relates to adults, but it's similar. The facial features are quite coarse, and the eyes don't even seem to be able to open fully, and the tongue seems to be large. The babies often have a hoarse cry. They have feeding problems. They have constipation, macroglossia, large tongue. They often have, like this little girl, she had an umbilical hernia. Almost all babies with congenital hypothyroidism have an umbilical hernia. And they're floppy, a bit like babies with Down syndrome. In fact, sometimes they're mistaken for babies with Down syndrome, and sometimes children with Down syndrome also have hypothyroidism. So the two things are quite related, but most children with hypothyroidism don't have Down syndrome. They often get cold, hypothermic, or have bradycardia, the other features of hypothyroidism, and they have prolonged jaundice, particularly this unconjugated hyperbilirubinemia. So if you see a child who's got jaundice and an umbilical hernia and a big tongue, then maybe they've got congenital hypothyroidism. There's lots of different causes of congenital hypothyroidism, iodine deficiency only being one, and some causes are central hypothyroidism. So, for example, mostly it's a problem with the thyroid gland itself or a problem with iodine, but sometimes it's related to what we call central hypothyroidism, which is related to thyroid stimulating hormone not being released by the pituitary gland. And so we need to think about primary hypothyroidism involving the thyroid gland itself and, excuse me, Okay, I've just got to go shortly. We need to think about central hypothyroidism, which relates to thyroid stimulating hormone from the pituitary gland. And sometimes children who have central hypothyroidism also have other hormonal problems. They might have hypoglycemia because of lack of growth hormone or ACTH, or they might have a micropenis. They might have like ambiguous genitalia because of lack of gonadotrophins, or undescended testes because of lack of gonadotrophins, or they might have diabetes insipidus because they don't have enough vasopressin. So there's central hypothyroidism, and hypothyroidism that relates to just the thyroid gland itself. About 80% of all types of hypothyroidism occurs because of a problem with the formation of the thyroid gland, either thyroid dysgenesis or agenesis. There's lots of different types. And about 15% are inborn errors of thyroid hormone metabolism. So even though the thyroid gland is normal, the thyroid can't make enough thyroid hormone. But then some, of course, relate to iodine deficiency, more common in mountainous areas, especially where there's a lack of like fish and sea salt, because sea salt contains iodine, as you know. And it's been found recently in the last few years in Chimbu, more babies who have endemic cretinism. Thyroid hormone is normally, if a mother is deficient in thyroid hormone, if she's hypothyroid, then her baby will be hypothyroid too. And that is really important for maturation and development. So for the first 12 weeks or so of gestation, the fetus is completely dependent on maternal thyroid hormone, and then it's only after that that the fetus starts to make thyroid hormone. So if the mother's hypothyroid, then the baby will be have significant developmental delay, because there's not been development of there's not been enough thyroid hormone around in the first trimester of pregnancy. The diagnosis of hypothyroidism, you can diagnose primary, that is thyroid gland hypothyroidism, by a high TSH. So the pituitary keeps putting out a lot of TSH, but the thyroid gland can't make T4. Or central hypothyroidism, where the pituitary is not putting out any TSH, and there's a low systemic or blood T4. So a low TSH with a low T4 means it's central, and a high TSH with a low T4 means it's related to the gland or iodine deficiency. And then there's some children that have subclinical hypothyroidism. Their TSH may be high, but their T4 is normal. So they don't actually have hypothyroidism. For some reason, their pituitary gland is just putting out more TSH. But just know how to distinguish primary from central hypothyroidism. That's probably most important. The aim of treating children with hypothyroidism is really to make sure they have enough thyroid hormone on board by the end of the first month of life. So if children are diagnosed after the first month of life, then they often have severe mental retardation, severe developmental delay. But if you can get thyroid hormone into them by the first month of life, then usually their development is pretty good. And there's a way to monitor the amount of levothyroxine that you give them, and that involves looking at their T4 levels and making sure that they're good enough, their T4 levels is high enough, and their TSH is suppressed. That's usually what we do. So if you've got a normal amount of thyroid hormone in your blood, then your TSH won't be very high, but your measured T4 will be high enough. So that's the aim of the management of children with hypothyroidism. And as I say, usually if you start treatment within the first month of life, then their mental, intellectual development is usually pretty good. I wanted to just just say again that remember I said there's a number of different causes of growth failure, and mostly when we look at growth charts, we don't look at growth charts that look like this. We're looking at growth charts where children have started off being normal and then they drop away. They start off being normal length or height and then they drop away. and this is the length for age for girls. And you can see this child started off being low and stayed low. Again here, started off low and stayed low. So when you see that, you should think that it's probably not related to primary malnutrition. It's probably something constitutional or inherited, like a genetic cause, or maybe an intrauterine cause. Maybe that child had some intrauterine problem, or it's a hormonal cause or an endocrine cause. But now, if you see a child with malnutrition, usually they start off normal and then they drop right away. So you can tell a lot by the growth chart by plotting both the weight and the length. Okay. So today I wanted to just really cover diabetes and everything about diabetes and diabetic ketoacidosis. And then I wanted to briefly cover growth failure related to genetic or hormone abnormalities. And so they're the two things today. I'll send around the slides and you can review them. But I really want you to be good at the management of children who've got diabetes, because I think we'll probably see more of it. And I want you to be able to distinguish, to differentiate different types of genetic or hormonal growth failure. That's basically it. I'm happy to answer any questions that you might have now.
Okay.